Welcome back to Corium. I'm Brian Gilberti, and today Dr. Ellen Duncan is back to help us dissect another pediatric EM topic. Great to have you back, Ellen.
Always great to be here.
Now, today we're diving into group A strep infections, and they're so incredibly common in the emergency department, yet they still manage to surprise us. So let's kick things off with a classic presentation, our good old strep throat.
All right, let's start with the basics. Group A strep, or strep pyogenes, is a gram-positive bacteria that doesn't just live in the pharynx. It can also colonize places like the anus and the genital mucosa. And if it feels like you're constantly seeing strep in the ED, you're not wrong. According to NIH data, there are an estimated 289 million cases of strep pharyngitis every year in kids between 5 and 14 years old. So yeah, we really do see it all the time.
Yes, we see it, we think about it constantly, and for parents, it's the ultimate boogeyman. Now walk us through your approach to the typical sore throat kid. What clues scream strep to you?
So let's imagine a healthy 10-year-old girl who comes to the ED with fever and sore throat. On exam, her throat is maybe a bit red, and she has some anterior cervical lymphadenopathy. What's your next move? What are you thinking about for her workup or treatment? Now let me add a twist. What if she also has a cough? Does that change your differential or how you're approaching the case?
Perfect, Ellen. And you're hinting at the Centaur criteria, which is absolute bread and butter for adult providers. But remind us how it works and whether it actually holds up in pediatrics.
So the Centaur criteria were really designed to help estimate how likely it is that someone has strep. Basically, it's a point system. You get 1 point for each of presence of fever, tonsillar exudates, tender anterior cervical lymphadenopathy, and absence of cough. If you checked out the modified score on MD Calc, you'll notice it also adds a little weight based on age. But there's a key thing to remember. These criteria were originally developed for adults, so think patients 16 and older, to help guide decisions about testing and antibiotics. So when it comes to the younger kids, more recent studies show that the Centaur criteria just aren't that helpful. And in pediatrics, we can't really rely on them in the same way.
Now that's gospel right there. Adult tools do not always translate to pediatrics. And let's say it a little bit louder for the people in the back. When you're at the bedside, Ellen, what specific exam findings make you highly suspicious for strep?
So in addition to the usual signs of tonsillar inflammation and anterior cervical lymphadenopathy, there are a few other classic features of strep you'll want to keep an eye out for, including palatal petechiae, strawberry tongue, and perioral pallor. And don't forget about scarlet fever. That's when you see the famous fine sandpapery rash, which often starts in the trunk and spreads outwards. Later on, you might notice desquamation, especially on the fingers and toes.
Okay, now for the vague complaints like abdominal pain or headache, they always seem to end up getting a throat swab on your side of the ED. So tell us, what's your threshold for testing when the exam is mild or ambiguous?
So it's super common for kids with strep to have abdominal pain or headache, even when the throat doesn't look too impressive. Honestly, I personally have a pretty low threshold to test when a child comes in with fever plus either of those symptoms. Luckily for us, we have access to the rapid PCR, which has a very high sensitivity and specificity. Many centers have a rapid antigen detection test, which is highly specific, but then is usually sent for a throat culture if it's negative, since the culture is more sensitive.
Now, we covered who to test, but let's flip it for the harder question. Who doesn't need a swab or antibiotics?
Right, so in general, we don't usually treat or test kids under 3 for strep because rheumatic fever is so rare in this age group. But that doesn't mean we ignore it completely. I'll still test younger kids if they're showing symptoms and have a close contact who was recently diagnosed with strep.
Perfect. Makes sense. Now, going through my list of questions for you, another common one, should we treat everyone in the household if someone tests positive for strep?
So for pharyngitis, prophylaxis for asymptomatic contacts isn't routine, but it is considered for households with recurrent infection or a history of rheumatic fever. For invasive group A strep, which we'll talk about later, the recommendations are a little more aggressive, and prophylaxis is recommended for household contacts who are immunosuppressed, pregnant, those who have had recent surgery, or anyone with an open wound.
Solid guidelines, and I think at this point we've tackled the evaluation and the frequently asked questions, but let's pivot to management, Ellen. What are your go-to antibiotics right now?
So thankfully, group A strep has remained susceptible to beta-lactam antibiotics, which definitely makes our job easier. My go-to is usually once daily amoxicillin at 50 mg per kg, maxing out at 1 gram per dose. But I also like to offer IM penicillin G or bicillin, especially for kids who struggle with oral meds. It's one shot and you're done, which can be a lifesaver for certain families.
Nice. Very straightforward. Now, the million-dollar question for parents, when can their kids go back to school?
That is definitely the question of the day because we all want our kids to go back to school. And the guidance on that is clear. Patients can return after 1 full day of treatment, so between 12 and 24 hours, as long as they're also afebrile and generally feeling well.
Great. Now, another sometimes confusing question. What about that bounce back kid, the one that finished their amoxicillin and a week later the sore throat returns? Do we just retreat them, or what's our move?
Yeah, so this is a super common scenario, and we have to figure out if it's a true treatment failure or a new infection, or if we're just unmasking a chronic carrier. For that latter scenario, the prevalence of group A strep carriage in children can be as high as 2 to 20%. And these carriers test positive, but they're asymptomatic, so the strep isn't causing their illness. They're also at a very low risk for transmission or complications. If, on the other hand, you suspect a true treatment failure, you have to ask why the treatment failed. So one of the concepts to consider is the shield effect. The patient's throat may be colonized with other bacteria like Staph aureus, H. flu, or Moraxella that produce beta-lactamases. These enzymes essentially shield the group A strep by chewing up the amox before it can actually work. So for that bounce-back kid, the fix isn't just more amox. You should use an antibiotic with greater beta-lactamase stability. Think amoxicillin or one of the first-generation cephalosporins.
Yes, and that's the critical takeaway. Many of us aren't familiar with the shield effect, and it's important to distinguish it from true resistance. Now, once treatment is underway, what complications should we be watching out for?
So there are several potential complications. In terms of suppurative complications, there's a long list, including peritonsillar abscess, sinusitis, meningitis, and bacteremia. We'll talk about invasive group A strep in a bit. Non-suppurative complications include rheumatic fever, which typically presents 1 to 5 weeks after infection with those classic Jones criteria, and post-infectious glomerulonephritis, or PIGN, which also presents several weeks after initial strep infection with hematuria or that classic Coca-Cola colored urine. Make sure to remember that strep and impetigo can lead to post-infectious glomerulonephritis as well. For those non-suppurative complications, remember that we treat strep to prevent the development of rheumatic fever, but treatment does not prevent post-strep glomerulonephritis.
Let's shift gears and talk about the bad actors, and specifically invasive group A strep. What do we need to know?
Yeah, I think it's really important to talk about invasive strep for a few minutes because it definitely feels like we're seeing more and more cases over the past few years, and the data actually back that up. According to the CDC, rates of invasive strep have been climbing since 2014, with a pretty sharp spike in 2023. It's a good reminder to keep this on our radar, especially when kids aren't following the typical strep course or are just really looking sicker than you'd expect.
So, Ellen, I want to back up for a second. When we say invasive, what specific types of infections are we talking about?
So there are a whole range of invasive group A strep infections to watch out for. Things like strep toxic shock syndrome, neck fash, meningitis, bacteremia, and even peritonitis. But honestly, the ones I feel like I'm seeing the most often, and the ones I really want to highlight, are the bone and joint complications like septic arthritis and osteomyelitis, which can often show up alongside pyomyositis. These kids tend to come in looking really sick, and you get that gut feeling that something more serious is going on.
And since these kids look so deceptively well early on, what specific findings make you stop and think, okay, this could be invasive strep?
So part of what makes invasive strep so tricky is that the symptoms are often really nonspecific. These kids might just come in with fever or not acting like themselves, maybe some localized pain, but nothing that screams this is invasive strep. Kids with septic joint or osteo might have a limp or focal pain, but you won't always get that lucky. When you have a patient that sets off your spidey sense, that's when you really want to cast a wide net. You're thinking broad workup, including blood cultures, CBC, chemistries, and inflammatory markers like CRP and ESR. And don't forget imaging, which can be super helpful. You'll want to tailor that to where you suspect the problem is. Maybe you'll start with an X-ray and an ultrasound if you suspect a specific joint, but you're probably going to be reaching for an MRI if you're worried about deeper infections like osteo or pyomyositis.
And Ellen, once your index of suspicion is high, what's the initial treatment plan?
So when you're managing these patients, you want to start broad-spectrum antibiotics like Vanco and Pip/Tazo. For patients presenting with signs of shock, it's important to also consider adding clindamycin or linezolid, which can reduce exotoxin release, and these are critical in managing severe infections and preventing further complications.
Great. And this is a crucial point that I want to highlight. We must add clindamycin to our vancomycin and zosyn if we suspect these cases, and specifically for its effects on exotoxins. Is there anything else we should be keeping in mind when confronting these types of presentations?
So one thing I noticed in the cases that I saw was really how much overlap there can be between invasive strep and Kawasaki disease. There's actually some interesting data out there showing that the superantigens produced by strep might activate a common inflammatory pathway, particularly through T-cell response, that can contribute to the development of KD. In fact, some studies have shown that kids with invasive strep infections may be at higher risk for developing Kawasaki disease. So it's a good idea to get rheumatology involved early. They'll appreciate all of those inflammatory markers you've sent over, And it can really help figure out if the patient is on that Kawasaki path or if they're dealing with something else.
Perfect, Ellen. As always, we can count on you to distill these complex topics into digestible pearls from the PEM realm. This was really a masterclass in everything from strep throat to toxic shock. So thanks again for joining us.
Thanks again for having me.